On Twitter, Mike says, according to a recent study from Yale, there are 68,000 excess deaths per year that can be attributed to people who delay or avoid care because they lack health insurance. What do you attribute their deaths to? Magic? No, it is the structure of our healthcare system. I disagree. This is the paper he's referencing, associated with the Yale School of Public Health, published in The Lancet, and they do indeed estimate that ensuring healthcare access for all Americans would save more than 68,000 lives. Their estimation is explained here in Figure 4. What they do is they figure out how many people in different age groups lack insurance. And then they say that uninsured individuals experience a 40% elevation in age-specific mortality, meaning you're 40% more likely to die if you lack insurance. And so from these two things, they figure out how many lives would be saved. Here they explain that in text. Given that uninsured people experience a 40% elevation in age-specific mortality risk, and they tell us their source, which is this paper, Health Insurance and Mortality in U.S. Adults. They find the uninsured were more likely to die. Hazard ratio is 1.4. The results are based on a survey where they have 9,004 respondents. So this is an observational study. They aren't randomizing people into groups. They're looking at survey data where they have 9,004 respondents, and they find that people without insurance are likelier to die. The problem with this is that the 1.4 times more likely to die, or 40% elevation in age-specific mortality, is not the only estimate for mortality risk for uninsurance, and it's not the best estimate either. Here's a second paper, Health Insurance Coverage and Mortality Revisited. This second paper is also observational. They look at survey responses from 673,000 respondents. Would you like to guess what they found? In their conclusions, the paper's author reminds us that it is not possible to draw firm causal inferences from the results of observational analysis. So because this isn't a randomized controlled trial, we're just looking at data after the fact, we can't make firm causal inferences. We can't say uninsurance causes something for sure. But there is little evidence to suggest that extending insurance coverage to all adults would have a large effect on the number of deaths in the United States. More specifically, they estimate the hazard ratio for the uninsured is 1.03, a 3% increase in mortality, with a confidence interval that overlaps 1, meaning it's not statistically significant. Again, from the conclusion, the answer suggested by the evidence presented here is that there would not be much change in the number of deaths in the United States as a result of universal coverage. Although again, the difficulties in inferring causality from observational analyses temper the strength of this conclusion. Okay, let's try a paper that's not an observational study, but is instead randomized and controlled, and has a much larger sample size. This paper, I'll call it the third paper we're looking at, involves an IRS letter that was sent to 3.9 million households. What happens is there are 4.5 million households who didn't have insurance that met criteria for the IRS to send them a letter that basically says, hey, buy health insurance. 3.9 million of the 4.5 total were randomly selected to be sent a letter. So we have random selection. And this intervention, sending them the letter, led to increased health insurance among the people who received it relative to the people who randomly did not receive the letter. The paper authors look for whether the additional coverage induced by the intervention, more people getting health insurance because they received the letter, reduced mortality among those who enrolled. We find evidence that it did. In the 2 years following the intervention, the mortality rate among previously uninsured 45 to 64-year-olds was lower in the treatment group, people who received the letter, than in the control group by approximately 0.06 percentage points, or 1 fewer death for every 1,587 treated individuals. We find no evidence that the intervention reduced mortality among children or younger adults, younger than the 45 to 64, or younger adults during this time period. That's a problem because when we go back to the Yale study, they remind us that these are predominantly the lives of young people who are uninsured. Given that most individuals older than 64 are already covered under Medicare, adults aged 25 to 35 are disproportionately represented, accounting for more than 9 million of the uninsured. But remember, adults aged 25 to 35, according to this paper, there is no evidence that the intervention reduced mortality. One more randomized controlled trial. In this paper, the authors are looking at people from the state of Oregon who were randomly selected to either receive Medicaid or not. So they've got 6,000 people in the Medicaid group, 6,000 in the not, and they're going to look at biometric data and compare them. They write that Medicaid coverage had no significant effect on the prevalence or diagnosis of hypertension or high cholesterol or on the use of medication for these conditions. It had no significant effect on the prevalence of measured glycated hemoglobin levels of 6.5% or higher, which I understand to be connected to diabetes. We chose these conditions because they are important contributors to morbidity and mortality, feasible to measure and prevalent in the low-income population. In other words, if it were the case that health insurance made you less likely to die, then we'd expect that to be mediated by the things that signal morbidity and mortality risk, by these biometric indicators. And yet the study authors here didn't find any significant benefit to these biometric indicators. They do write that people were less depressed. It reduced mental health, self-reported mental health issues, but it didn't change the biometric data. Back to the paper from Yale. The issue here, they write, given that uninsured people experience a 40% elevation in age-specific mortality risk, the issue here is that they chose 1, the smallest sample size, 2, an observational study, and 3, the paper with the largest estimate for the elevation in age-specific mortality risk to base their conclusions off of, without any discussion or explanation for why they were picking this estimate as opposed to the others, all of which, except maybe the IRS one, existed at the time that the Yale authors were writing. So I think they're just selecting an estimate to make their numbers sound as big as possible. Let me see if I can do some mental math to try to correct this for some of the bigger papers that we looked at. So if instead of 40% it was 0% elevation, how many lives would be saved by extending Medicare for all? I guess 0. Now, I was just being glib there. I'm not really defending the claim that Medicare for all would save 0 lives. I would say I don't really know. I feel a lot of uncertainty about it, in part because there are conflicting elements. I also don't want to pretend like I've shown you every paper out there that estimates the mortality risk from uninsurance. There's a lot of papers out there on this topic, and I haven't read all of them, or even most of them. I've just shown you some papers that I looked at in hopes that I'm introducing more uncertainty to this claim than is currently expressed in a tweet like this. Finally, I just don't have that much confidence in the 68,000 number. The Yale paper is much more like a political advocacy piece than actual scientific research, and I think they're engaged in motivated reasoning to select evidence to support the point they want, without thinking about contrary evidence, as I hope I've shown here. Thanks for your time.